Hey y'all, welcome back to my channel. I'm Muriel. This is Nurse Muriel. Sorry, it's been a few days, y'all. I've been working. First off, I want to say welcome to my new subscribers. We are currently at 642. Welcome to my oldies but goodies. I really appreciate everyone who views my videos and every last one of you who decide to hit that subscribe button. I had to make a run to the library. Had another order for one of my booklets, y'all. Don't forget about my nurse brain booklets. I have them for long-term care and acute care. There to help you give a thorough and accurate shift report to your oncoming nurse. This one is in pink, but I have them in green and blue as well. And if you don't know, what I have available is all I have available. I won't be making any more, so what I have on hand is all that I have available, and I think I only have one of pink of the long-term care left. But anywho, I'm making this video because I worked yesterday at a long-term care facility. This facility is going through some changes. I received a text message one day last week, and this is the facility that I was once a supervisor every other weekend, and I asked them for a pay increase, and they refused the pay increase, and so I went back agency with them. Well, corporate has decided to give pay increases across the board for PRN staffing. They are going to be paying, basically the PRN staff is going to be making what the agency staff pays. Like, they're going to be making that. And I was like, y'all, I only asked y'all for $2 more, and y'all refused to give me $2 more. Now, if I come back as PRN, y'all are going to pay me $4 more. So y'all already know. While I was working my agency shift with them yesterday, and I also have 4 more shifts with them through agency this month, I went ahead and got my PRN package, y'all. Went ahead and got my paperwork to come back as a PRN employee. They're just basically cutting out the middleman. They're cutting out the agency, y'all. This is a smart move. They have an incoming orientation of like 8 nurses coming in as PRN. So y'all know I'm gonna be one in the number. I don't think I actually have to sit through the orientation though, because I just went through the orientation with them in June of last year when I went on staff. Even though I'm agency now, but anyway, just to let y'all know that look how it worked out. Now I'm gonna be going there as a PRN staff making $4 more an hour. I'm gonna see if I can reprise my role as every other weekend supervisor, because y'all know that was 8-hour shifts, and I rolled through there the 8 hours that I wanted to roll through. I actually ended up working there Sunday because the RN they had scheduled for duty, you have to have 8 hours of RN coverage every day in long-term care. The RN they had on duty called out, and so they needed to get an RN in the building. And they got one of the staff members reached out to me, and I went in and did their RN coverage for Sunday. And actually, y'all, ended up, between me and you, I only worked 5 hours. They ended up paying me for 8 because they needed an RN coverage in the building, so they put it for 8 hours. So yeah, I worked yesterday as well, y'all. So I worked with them yesterday, and I worked on the hall, and I was supposed to get 2 admissions. Y'all, if you ever work long-term care, when you hear you getting an admission, it just be a sense of dread, because it's a lot, but then it's not a lot behind doing the admission. The only thing with this facility is they no longer have a unit manager, and so the nurse who's receiving the admission, it's kind of falling on her to put in the medications. I think the hardest thing about doing the admission is actually putting in the medications, y'all. And then there's a bunch of little extra things that have to get put in that I'm not familiar with how to put it in. It's like a preset protocol type thing, and I'm not familiar with how to put that in, but luckily I know how to put the medications in. So I was going through, I got the discharge summary probably about 3 hours before the patient arrived. So about an hour to hour and a half for me to put the medications in, y'all. And this is why I'm working the cart. Now, I'm not just sitting there doing the admission. I'm actually working the floor. It took about an hour and a half to get the medications in. Y'all, I'm supposed to get off at 7. Guess what time the admission come rolling through the door, y'all? I tell y'all no lie. He rolled through at 6:45. He rolled through that door on that stretcher at 6:45. Y'all, I was like, you know what? he rolled through on me, so I have to put the admission note in. But I went a step further. I actually did the body audit as well as the pain assessment. Um, you know, but y'all don't be afraid of admissions. If there is someone that can putting the medications in is the bulk of an admission, because you have 24 hours to get admission fully in. But here's what I do when I get an admission. The first thing you should do is get a call from the hospital or the other facility that they're coming from. You should get a thorough breakdown of everything about this patient. When you finish with that phone call, you should know how that patient eats, whether their meds are whole or crush, how they their behavior. You should know if they have any areas on their body. You should know their last set of vital signs. You should find out when was their last bowel movement. You should know, do they require oxygen? You should know if they're ambulatory, if they're continent, incontinent. Do they have any devices? Find out if they have a pacemaker. Do they have a colostomy? Do they have Foley's? Like, are they coming with a PICC line? If they're bruising, if there's wounds, find out, are there any wounds? What were y'all doing for the wounds there? Find out if this patient is alert and oriented, if they're verbal, if they're nonverbal. Just find out everything you can find out about the patient from that phone call from the nurse. Once you do that and you find all of that out, just find out what's going on generally with their health. What were they admitted for? How did they progress during their hospital stay? How were they that day before they're being sent to you? Although this stuff will come to you in the discharge summary, but sometimes you may get the phone call to get report before you actually get the discharge summary in your hand. So find out as much as you can from that nurse that's going to call and give you a report. When the patient arrives on the floor, take notice of how they are. When they arrive, are they arriving by stretcher? Are they arriving by wheelchair? What's their demeanor while they're on the stretcher? If you're able to follow the EMT to the room. Once the patient gets placed in the bed, introduce yourself to the patient. Tell them who you are, how long. I always say I'll be your nurse until 7 p.m. or 3 p.m. Things like that. Do the signing and everything you need to do with EMT, because EMT is going to want you to sign that you received the patient. They're going to give you some paperwork. The first thing I do, if I have not received the discharge summary before the patient arrived, after I introduce myself to the patient, I make sure they're in bed. I hand them their call bell. I make sure they're safe. Bed is in lowest position. Before I even touch this patient, I try to do a quick run through of the discharge summary so that I can become familiar with some things about the patient outside of what the nurse told me, which 9 times out of 10, a lot of things are going to match just what the nurse told you. But sometimes there's little nuggets in the discharge summary. If the patient is there, don't take 30 minutes reading the discharge summary. Just go over it real quick just to get the gist. Like, you can even tell by some of the medications that a patient is on that there may be something going on. Like, if a patient is on Seroquel and Trazodone and Risperidone, that tells you a few things right there on its own. You know what I'm saying? If a patient is on Flomax, that tells you something about the patient. If the patient is on like Eliquis, or the patient is on Xarelto, Coumadin and stuff. I really don't see Coumadin no more, y'all. That will tell you some things right off the bat about the patient. Certain medications can tell you certain things about the patient. Once you do that quick run over, the first thing you're going to do with the patient, you're going to let them know, I'm about to get I'm going to go ahead and get a set of vital signs on you. I'm the type of nurse, I want to get the initial set of vital signs. Y'all, I'm not going to lie. I'm not going to lie, and I was a CNA, and that's why I can say this. I don't always trust the vital signs I get from others outside of myself. So I always want to get that first initial set of vital signs when they're coming through the door, and I want to do it once they're in the bed and they're settled, because sometimes the drive there, riding on the stretcher, hitting bumps, the anxiety, things like that, can cause the blood pressure to be elevated. So I like to give it a little bit to let the patient get a little settled and get their vital signs. So I'm getting a true a true set of vitals, not a whole hour or whatever, but probably like 10 minutes or whatever. Let them get settled, introduce yourself so they're a little calm, hand them the call, like stuff like that. I'm gonna go ahead and get a set of vital signs. Then I'm gonna explain to the patient that I need to look over your body. I just need to make sure to see if you have any bruising, any areas, anything on their body. We just need to get that initial body assessment done. But before I touch the patient, I ask them, are you having any pain right now? If they tell me, yeah, I'll ask them, where is your pain? So to be gentle with that area. You may need to even pre-medicate them before you do a body audit, depending on how bad the pain is. If they tell me they're having some pain and I ask, where's your pain? And they say in their leg, I ask, rate your pain for me on a scale of 0 to 10. And if they tell me like it's a 1 or a 2, I'll tell them something like, oh, okay, well, I'm going to do a quick body audit on you, and I'm gonna probably go grab you some Tylenol or something for your pain. Most of the time they're very, very agreeable with that. So I go ahead and I do a quick body audit. I look over their skin. I start from head and I work my way to the toe, y'all. While I'm doing all this, they may be moving some of their limbs, so that's telling me right then and there that if they have how their range of motion is, like if they're able to turn themselves for me to look, if they're able to lift their leg, lift their arm, stuff like that, I can assess their range of motion. Before I even get to the body, I'm going to look in their eyes. I'm going to make sure that their eyes is the eyes are equal and reactive. I'm going to ask them to open their mouth so I can see in their mouth, see if they have any broken loose teeth, or what's going on. Do they wear dentures? Once they turn back over or whatever, I have them, sit in the sitting position as much as they can. Check the vitals already, so I know what they're satting as far as oxygen or whatever, because I don't want to lay you down if you're satting 82%. You need to be put on some oxygen before we even get started. So that's why doing the vital signs is really essential before you get started. And then I'm listening to their lung sounds every year. I listen to the lung sounds. Everybody don't do this, but I'm going to listen to your lung sounds because that's good to having a baseline to know, what if they're wheezing or, and then sometimes with the medication orders, like I said, some of the meds can tell you some things. If they're coming over with a PRN order for dual nab, that tells you something about them. If they're coming over with albuterol, Atrovent, certain, respiratory medications, it tells you something about their status. So you may need to, this patient may need to be placed on some oxygen. 9 times out of 10, they're coming over. If they're needing to be on oxygen, they're going to be on oxygen with the EMT. So to just go ahead and have an oxygen concentrator or a tank in the room, something like that. So and that, honestly, y'all, that can all get done in like 20 minutes. That quick once over assessment of the patient, listen to their heart, stuff like that. That all can get done in like 20 minutes. As you're doing their body audit, you're noticing, do they have a pacemaker? Do they have a shunt in their arm? Things like that you will need to document in your admission note. Find out if they want something to eat or whatever. If they're hungry, grab them a quick snack, as long as you know what their diet order is, which that should be in the discharge summary. So you should know if they can, what their diet order is. Like I said, orient them to the room. Let them know this is your call bell. This is how you alert us that you need some help. This is your bedside table. This is your roommate, things such as that nature or whatever. And then you find out if they need to use the bathroom or anything before you leave, if there's continent, before you leave out of the room. And then when you actually sit down and put your assessment in, y'all, and that 20 minutes that you looked over that patient, you asked those questions, you did that, you can have that admission put in within an hour. You can have that admission put in within an hour. It really doesn't take long to put an admission in. It just seemed like it's so many boxes to check off that it's going to take you forever. But if you did those steps, you looked over the patient, you looked in their mouth, you listened to their lungs, you had to move their arms, legs, things around to see how they are with that. You can basically, and while you're talking to them, you can tell if they're hard of hearing, if they're verbally, if they're coherent, incoherent, if they're confused, like things like that. You doing that 20-minute one over on that patient, you can basically sit down and do your whole admission in like an hour. So I used to be scared of admissions because I didn't have this system set up. Like this isn't the system I had to do in my admissions. So I would be doing a lot of running back and forth to the patient, like like when you get to this next section and you have to check this and you'll be like, oh, I forgot to look at this. So you got to run back to the patient and look at this. Then you run back and then you get to another section. You're like, oh, I forgot to look at this. And you got to run back. So I learned very quickly how to look at all that stuff while I'm in the room with the patient for like 20 minutes to look at all that stuff. So I didn't have to do all that running back and forth when it came to doing the assessment. And so I kind of advise you to do the same. It'll make putting the assessment in so much easier, y'all. I'm not gonna lie to you. I'm no longer afraid of admissions, y'all. If I hear I get an admission, like, I like to know that I'm getting the admission, though. Don't just spring. Like yesterday, I didn't know I was getting an admission. They didn't come tell me. The only reason I found out I was getting one is because one of the techs saw another name on the door. And they were like, are we getting somebody today? I hadn't seen that name on the door. And so when the admissions person came walking around, I asked her, I said, am I getting admission today? And I was actually supposed to get 2, y'all, but the person whose name was on the door didn't even show up. It was another one. And they were like, yes, we got a guy coming to blah, blah, blah. And I was like, y'all don't tell people, y'all don't let the nurse know. And that's when, they basically told me, it's not on the admission person to let us know. That information was relayed in morning meeting, and the unit manager or whoever was supposed to let us know, but being that there wasn't a unit manager on that floor, the unit manager for the other floor, she neglected to tell me the deal when no one came and told me I was getting admission. That alone, y'all, really kind of pisses me off, because even though I have a technique for admission, when they tell you you're getting admission, they can tell you like an estimated pickup time, so you can kind of plan your day, because I like to have nothing else to do during that time that I'm getting that admission, because I like to be able to designate at least an hour and a half to doing the admission. And so it just so happened that admission wasn't due to be picked up until 3 o'clock. So that gave me time to get my other patients in order. Like, I ended up having to do treatments and all because the treatment nurse had to leave. So that gave me enough time to get my other patients situated. So when that admission came, even though admission didn't show up to 6:50, when I got the discharge summary, I did get it prior to the admission coming in. I was able to sit down. I was able to give it an hour, and I was able to sit down and get these medications then. And that was a big help, because if medications are in, that's something that unless you don't have the discharge summary, unless there's a reason for you not to get it in, that's one of the big things that they want you to get in because you get their medications in, and pharmacy can send their meds that night. So my admission rolled in at 6:50. I had already had the meds in. I was able to put in a complete body audit. I was able to put in an admission note, and I was able to put in a pain assessment. There are other things that need to be done on admission, but a lot of those things you can't do until the patient get there, and being that he just got there at 6:45, I wasn't able to complete. I could have completed those things, but I wasn't staying over to complete. I'm not gonna lie to you. They got 24 hours to do that admission. They can work on it along, like the bowel and bladder assessment. I know those things because I know from the guy coming in how, but I'm not about to sit down and do that stuff, and he just rolled in here at 6:45. But they were very appreciative for what I did do, because there was no unit manager, and there's no, they said that they're so used to agency nurses just not doing anything at all. Which y'all know how I feel about that. I don't know why agency nurses come to buildings and just all of a sudden they don't know how to do anything, even though you did this at your home building for however long you was there. Now all of a sudden you're at this building and you don't know how to do anything. I don't understand it. But yeah, guys, I know I'm rambling. I hope y'all enjoyed this video. My energy is kind of low, y'all. I know why my energy is kind of low, but I'm not going to get into that. My energy is kind of low, but I just wanted to go ahead and make this video. Hopefully you made it all the way through and it was helpful to you. I'll be more upbeat on the next video, y'all. Y'all have a good day. I'll talk to you later. Bye.